Hi guys, today I have with me two important things that you see on your exam table viva. Today I have with me a fetal skull and also maternal pelvis. Very important topics. I used to get scared personally in my final year exam whenever there used to be this that used to be present on the table. So I hope with this session today I can make you much more confident in answering questions on this topic. So first I would talk about the maternal pelvis. Over here in the maternal pelvis you can see that you have the over here, then over here you have your ischium, and here you have your pubic bone. So a few important obstetric landmarks that I would want to show you. First of all is the pelvic inlet. So in the pelvic inlet, the boundaries I'm going to show you with this pen are going to be, first of all, the sacral promontory. So the sacral promontory forms one of the margins. Laterally, the ala of sacrum, as you see, this is the ala of sacrum, is going to form a margin. Then you go ahead. This is your arcuate line till here. This arcuate line continues beyond this as the pectineal line or the pectinate line. This in entirety can be called as the iliopectineal line. Very important. The arcuate line plus the pectinate line is the iliopectineal line. Over here, the pubic symphysis ka superior border will complete your pelvic inlet. So, sacral promontory, ala of sacrum, iliopectineal line, and superior border of pubic symphysis. Similarly, for pelvic outlet, you will have a few borders. There is one ligament that is missing over here. That ligament would have been like this. That ligament would have been sacrotuberous ligament, which extends between the tuberous, that is ischial tuberosity, and the sacrum over here. So what are going to be the borders? The borders are going to be the inferior margin of the pubic symphysis, then the line that connects the pubic symphysis with the ischial tuberosity, the sacrotuberous ligament. Only this much. So the outlet is made up of the inferior margin of the pubic symphysis, the line joining the pubic symphysis and the sacral, or rather the ischial tuberosity, and the sacrotuberous ligament. Now a few points to note. You see that in the pelvic inlet, the transverse diameter is going to be more than the anteroposterior diameter. So the transverse diameter more than the anteroposterior diameter, whereas at the outlet it is the opposite. The anteroposterior diameter is longer than the transverse diameter. इसका significance ये है that this fetal head has to engage in the transverse diameter. You can see that this is the occiput over here, this is the anterior occiput है यहाँ, this one. So it is going to get engaged in the transverse diameter. Then there is going to be anterior, or rather internal rotation, to make it anteroposterior, and when it reaches the pelvic outlet it is going to be anteroposterior for the head to deliver. So the longer diameter, that is your suboccipitobregmatic diameter, is occupying the larger diameter of that plane of pelvis. So इनलेट के यहाँ पे it is occupying the transverse diameter, outlet के यहाँ it is occupying the anteroposterior diameter. Okay, a few important diameters as well. Over here you have a true conjugate that extends from the middle of sacrum to the superior border of the pubic symphysis. That is your true conjugate. Whereas inferiorly you have your diagonal conjugate from the inferior margin to the same point on the sacrum. But the most important conjugate is going to be the diagonal conjugate that extends from this protuberance over here, from the, or rather behind the pubic symphysis, extending to the middle over here on the sacrum. That is called as the obstetric conjugate. So this is it about maternal pelvis. Coming to the fetal skull, over here you can see this is the anterior, this is the posterior. Unfortunately I do not have the mandible with me. So when I'm talking of this, the most important landmark that you can see over here is the anterior fontanelle. You can see that the anterior fontanelle is almost diamond shaped, and it is surrounded by 4 bones. You can see there are 4 bones, 1, 2, 3 and 4. So you have your 2 frontal bones and 2 parietal bones. Okay, if you see the other one, that is your posterior fontanelle, you see it is kind of fused. It is triangular in color, and it has only in shape, and it has only 3 bones surrounding it, the 2 parietal bones and the 1 occipital bone. Now the important point is that it is fused, because this is a term neonate that I have taken the skull of, whereas anteriorly the fontanelle is yet to fuse, because this will get fused by around 18 months of age after delivery. What is the significance of fontanelle? Whenever this baby is getting delivered through the vagina or through the pelvis, now assuming this is getting delivered in the flexed position as it should be, when it is coming in the flexed position, you can see, I'll show you this way. When it is coming in the flexed position, the only fontanelle that I should be able to feel is the posterior fontanelle, which is going to be fused. If I can feel the anterior fontanelle, it indicates that the head is deflexed or the head is extended. Both mean the same thing, and an extended or a deflexed head is going to find it very difficult to deliver from the diameter, from the vaginal outlet diameter, pelvic outlet diameter. What is the reason behind it? The reason is there are a few diameters that are associated with this. The two shortest diameters and the most favorable ones are going to be this is your occiput and this is your suboccipito-bregmatic. Bregma is basically the center of the anterior fontanelle, whereas vertex is the topmost point. You see this line? It is the topmost point on the skull. So your shortest diameter is going to be something below the occiput. So suboccipito-bregmatic diameter. This is going to be your shortest diameter. In this, the vertex is going to be the point of presentation. You see the vertex yahan pe is going to be the way your baby is going to come out. The other engaging diameter, which is going to be the shortest, is going to be submento, which would have been below the mentum or the mandible that I don't have. Submento-bregmatic. In that scenario, you would have it as the face presentation. These are the two shortest diameters, which measure around 9.5 centimeters. Which are the longer ones? The longer ones includes मेंटो वर्टिकल. सो मेंटो वर्टिकल इज बेसिकली यहाँ मेंटम से लेके वर्टिकल के बीच में. सो ओवर हियर you are going to have brow presentation. Brow presentation is an unstable presentation. It will either go into face or it will either go into vertex presentation. Apart from that, occipitofrontal presentation. Occipitofrontal presentation, again it is the longest diameter, almost 13.5 centimeters. It cannot engage in it, so it is going to be between the occiput and till the frontal bones. So occipitofrontal diameter. A few transverse diameters as well that are important over here. You can see over here on the parietal bones, you have these two prominences. These are the parietal prominences. This becomes the biparietal diameter, the longest transverse diameter. You have a few lesser important diameters like the bitemporal and bimastoid diameter as well. So that is it about the fetal skull. Now the process or mechanism of labor in simple terms. So there are two processes that are always ongoing whenever a baby is being delivered. They are descent and flexion. So the baby keeps on coming down and it keeps on getting ऐसा flex होते रहता है वो. So descent and flexion are continuously on. The other essential movements are going to be the baby gets engaged, then there is going to be internal rotation. The internal rotation can bring the occiput either anteriorly or it can take it posteriorly, making it occipito-posterior. Mostly it comes anteriorly. Once it comes anteriorly and it comes down, when the baby's head is out from the vagina, there is going to be extension of the baby's head, and then there is going to be restitution. Restitution is going to be in the same direction from where the internal rotation occurs. After restitution, there is going to be external rotation. That external rotation is now occurring because the shoulders inside are undergoing the same movements that the head underwent, which is why now the head has restituted and then externally rotated to come back to the original position. Original position मतलब यहाँ पे वो जैसे आया था, ओरिजिनल पोजीशन ये था, उसमें से इट स्टार्टेड रोटेटिंग एंटीरियरली, इट केम आउट एंड देन रोटेटेड इट लाइक दिस. You can also see that this is not coming out in the transverse diameter. You see this is not coming out. For that it has to rotate internally and become anterior for it to easily come out. This is a very good example of why internal rotation is very, very important. So that is it about mechanism of labor and maternal pelvis and fetal skull. I hope you all understood this. If you all have any doubts, please put it in the comments and I shall be glad to answer them with demonstration. So this is Dr. Aditya signing off and I shall see you in next video. Thank you.